Yes. Okay, perfect. My name is Elizabeth Shanker. I'm a pediatrician at Franciscan Children's. We are a post-acute care and rehab hospital here in Boston. And we, when I say we, myself and Cassie Thompson, who's one of our nurse practitioners, have a lot of experience caring for a patient with the ACT2 mutation, and can talk a little bit about rehab related to that. Also, Brian, do you want to introduce yourself? Or?
Yeah, I'm Brian Wishart. I'm a pediatric physiatrist. I work at Spalding, some of the outpatients, and then I do consults here at MGH. I'm trained a pediatrician and then rehab as well. Kind of take on the stroke clinic here, and so that's how we ended up doing the active too.
Great. Okay, no disclosures. So I think when people talk about rehab, often they're thinking about rehab from some kind of neurologic injury or illness. And that's certainly a big part of what rehab is. Did I do something?
No, just needs love.
Okay, needs rehab. Needs rehab. And a kind of a formal definition of rehab is to restore someone to health or normal life through training and therapy after illness or injury. And that certainly would apply to patients who have had a stroke or some other neurologic complication of any sort. And that's, I think, why we were in this section at the top. I think a lot of the focus of rehab is to think about functional ability, quality of life, and maximizing the patient's independence and function with their recovery, and also with where they get to when they're done recovering. Something that I think about a lot in the care of patients at Franciscans, because we take care of a lot of very young children, is that a lot of times when kids have had some kind of neurologic injury or illness, the area of the brain that's injured, or the neurologic system that's injured, is actually an area of the brain that hasn't developed yet. And so there's actually an opportunity as part of the quote-unquote rehab process to kind of allow those skills to be developed. And that's really what a lot of our therapists are doing is, for example, a lot of babies come to us after they've had a lot of respiratory illness. And they've been trached, they have a lot of oral, they haven't had an opportunity to develop their oral skills. When they come to rehab with us, they haven't lost the ability to eat, they just never gained it, and a lot of our therapists are working with them to, now that they're physically getting better and they're breathing better, develop the skills that you need for eating, as an example. And so a lot of what we do in the post-acute care setting is thinking about rehabilitation. And I would also expand the idea from just focusing on kind of neurologic injury and illness recovery to thinking about all kinds of injury and illness recovery, especially talking about this population. And I'm going to share with you the patients that we're taking care of, and I want to thank and acknowledge Lauren and Lydia for allowing us to just share some of our experience taking care of their son who has ACT2 and has had a significant difficult medical course, but also has had a lot of recovery over the 6 months he's been with us. So this is our patient. He's now 20 months old. He was born at 34 weeks gestation, and he has the ACT2 mutation. In addition to that, associated with that, he had Eagle-Barrett syndrome that's associated with bilateral hydronephrosis, where the urine gets backed up into the kidney, and I'm sure we're going to hear more about that in one of the future talks. And he has recurrent urinary tract infections. He also, as we heard about this morning, has pulmonary hypertension, and his pulmonary hypertension, as you would expect, is not responsive to nitric oxide. He has chronic lung disease and has a tracheostomy and is on the ventilator 24 hours a day. And he also is recovered from a patent ductus as well as coarct, which is both repaired. And he has a pretty significant GI dysmotility and is fed with a GGA and a G2. So for Raceland, we certainly focus on the neurologic recovery and helping him to grow his developmental skills, and he's made tremendous progress since he's been with us. But we're also focusing on a lot of the medical goals that we have for him to help him grow, get stronger, become more stable on the way to getting home. And so a big part of what we've been doing is pulmonary rehabilitation for him. And so the goal of this is to reduce symptoms, decrease disability, increase participation in physical and social activities, and to improve overall quality of life. And a lot of our goal is weaning the amount of respiratory support that he needs, and which is gonna happen naturally as kids grow and their lungs get stronger, which is what's been happening for Riesland, and getting him kind of slowly but surely needing less support so that he's safe to go home. And so our strategies have been to really kind of bring together a lot of what we've heard so far from all the different organ-specific talks, from cardiology, from pulmonary, from infectious disease management, to really optimize his chance to really have the gains that he can make during this recovery period. And so we've been maintaining respiratory stability. He's on a portable event. We're slowly weaning the vent. Everything's doing something right now.
Next. Next.
Yeah. Oh, there it is. It's not up there. So we've been working on maintaining his respiratory stability. Interestingly, and that was mentioned in the pulmonary part of it, he does not respond well to bronchodilators, and we know that. And so when he does need rescue, we're using things like Aftervent. He responds well to Pulmozyme, which was unexpected to me. It's not typical for kids. We're working on it. I can keep going, is that okay?
Yeah, for now.
Okay. We also, when we think about his pulmonary condition, it's really important to keep him as calm as possible, because when he gets agitated, that's when he starts to collapse his lungs. And so you're nodding. Yes. So a lot of, those are the kind of details that we're paying attention to as we day by day are taking care of him and helping him to get stronger and stronger.
Shall I recommend everybody take a 5-minute break and return while we work out the video issues?
Oh, wow.
Almost out of your way.
Sorry guys, I tried.
In addition, we are optimizing medical management. We use diuretics. And the other thing that's really important, and we have a wonderful nutritionist at Franciscan to help us really look calorie by calorie, day by day, ounce by ounce, to make sure that we're optimizing the growth, because as the baby grows, everything's growing. The brain is growing, the lungs are growing, and that's really where a lot of the recovery is, and we want to optimize every single minute we can for that. Similarly, we do a lot of medical, part of this is medical rehabilitation, and for Riesland in particular, he had been on a lot of sedating medications to help stabilize his lungs, which we wanted to peel back a little bit. That's part of rehab, is getting patients off of some of those sedating medications to for going home. And so we weaned him off those medications very slowly, and we were successful, and always balancing the pulmonary stability at the same time. The other thing we found is that he really struggles when he gets sick. We start to see a lot more autonomic instability, and so catching infections and preventing infections has been a really important part of, I think, the progress that he's been able to make, because the more he's stable, the more he's able to grow and get better. And so, for example, we have him on, he has a suprapubic tube to drain his bladder, and he gets frequent urinary tract infections, so we have him on prophylactic antibiotics as an example of the way we keep him stable. And again, nutrition is really important. Feeding is something we're also working on. It's quite a challenge. He has a G tube as well as a J tube, and a lot of GI dysmotility, which means that his intestines and stomach don't move the food through the way you would expect. And so nutrition can be very challenging. Right now he's fed through his J tube, so we kind of put the food a little bit further into the intestines, and he seems to get good nutrition from that. Our goal ultimately is to get him so that he can accept the food into his G tube, and that he'll get good nutrition from that. And we're, again, very slowly mindful that we don't want to cause agitation and compromise his respiratory status. We are working on giving him food through his G tube and clamping his G tube, and hoping that he, every day by day, gets a little bit better at tolerating it. I think what we've seen is just kind of lots of patience, a lot of attention to detail, and I give Cassie all the credit for that. And a lot of, and just kind of a lot of patience. And he's been with us about 6 or 7 months now, and has made a lot of progress, particularly around weaning the vent. He's making progress developmentally with the stuff he's able to do, and also I'm anticipating he'll continue to make good progress, and we're working on getting him home. So it's exciting. I'll turn it over to Brian.
Wonderful. So what I wanted to do is, after kind of talking with people yesterday, going through, I made some changes to my slides and made them maybe a little more general. And, you know, Patty gave up this nice timeline of what we expect after you've been diagnosed with the disease. And sometimes you've had a stroke beforehand, sometimes it happens sometime after, but really what do we expect once something has happened? You know, I think we've talked a lot about how to do to prevent it, but most of the families here have had some sort of issue. And where they land in that timeline that you said after the stroke happens and with the rehab, you know, the timeline can be blown up and really expanded from the PICU all the way till we get home, and as we progress through and make those home goals and get back into school and everything. So my role is fairly unique. I'm lucky enough to see the kids early on. I get to work with them. Carol was going to speak later in the PICU on certain kids, and so one of the big things that this goes across the board for all of our PICU patients, but particularly for our neurologic rehab patients, is early mobilization, early activity, trying to get them off sedation as early as possible and get them up, awake, alert, and moving can be helpful in terms of mitigating any risk for any future complications. And that's really our goal as a physical medicine rehabilitation consult in the PICU. Is we want to make sure that anything that goes on while you're there in the PICU isn't going to limit your progress and your rehabilitation and recovery later down the road. So pressure sores, ulcers, that type of stuff, any sort of contractures within the muscles. So if we're not moving very quickly, we were talking with one of the families yesterday, and you lose muscle very quickly. Within 48 hours, you can start to get atrophy and losing muscle, and it takes a while to recover it. So if we can get you active, get you standing, get you out of bed as quickly as possible following an incident, and this is all within kind of the safety of the PICU. So the PICU protocols, all that is kind of number one, and then after that, we're pushing them to try to get the kids up and moving as quickly as possible to try to prevent that atrophy and those contractions from happening. And then there's the risk of delirium within the PICU and being awake off of sedation, that kind of stuff can help limit that. Having PT and OT involved early is one of the big keys with that. And a nice little picture on one of the slides of kind of the whole team. So the big thing is it's a big team approach, right? So we have case management, social work, your intensivists, the physiatrists involved, physical therapy, occupational therapy, speech therapy. All of this is dependent very kind of specifically on what what deficits you're getting from whatever the neurologic insult is. And then the other side of this is kind of developing that relationship that's going to be ongoing once you leave the PICU, go to the acute floors, and then go to either an acute rehab hospital or outside. And being able to set up those expectations of what this process and what this marathon is really going to look like down the road. You know, you have everything going on, and it's so crazy in the PICU at those times when, you know, things are buzzing, there's nurses everywhere, there's so many people, but this is a long road, and kind of having that expectation that this isn't gonna, once you're out of the PICU, it's still a lot of steps to get back to where you want to be, I think is important. So once we're out of the PICU and we're stable and we're doing that, you know, our goal is to get patients into rehab and starting moving and doing things as quickly as possible. And so there's a couple different steps. So typically you go down to the inpatient floor, and then after that, there's several different places that you can go. Sort of the highest level would be your acute inpatient rehabilitation hospital. So that's Franciscan's, Spalding has one. There's some differences to different places, and they're scattered about the country. Sometimes the pediatric portions are a little harder to come by, which I think some people have found that they're just not as accessible, but they're around. And typically it's an inpatient, you're staying there. So if you do have to travel, it's sometimes not the worst thing. So there, you know, the goals of this are going to be a interdisciplinary approach. So there's a couple different ways of doing this. There's multidisciplinary and interdisciplinary, and there's a lot of talk about which is better, which is different. They all sound sort of the same unless you really dig into it. And really the goal of interdisciplinary is that you're working kind of one-on-one. So PT and the OT are sharing goals, and they're working towards the same goals in different approaches, and maybe working together in their sessions versus kind of working in parallel moving forward. And, you know, for these complex kids, I think that interdisciplinary approach where you're really kind of hitting everything from different angles is the way to go about it. And you have a big team, right? It's going to be a lot going home. You have a lot of needs once you're home, whether it's accessibility, equipment, you know, outpatient therapies, how am I going to get them back to school, how am I going to, everything. It just feels like there's a million things. And so that's one of the benefits, I think, of going to an inpatient rehab is, in addition to the medical aspects of things with the physiatrist as well as a pediatrician typically in these places, you have your therapist, rehab nursing, but you also have case management and social work that can really help kind of guide you through that process, which can be really complicated at times. And then you involve a whole slew of other people depending on what deficits and what needs your child has, from pulmonology. You're seeing everybody here. Typically they're able to involve, whether it's over the phone or in consultation, that during that process. It's usually a big team approach. The other part that's not always depending on where you are, some programs have a really good school program and other ones don't, and it's more set on the school district that they're in. But I think the key is to have somebody in your setting, in your rehab, that's helping you with the discharge, communicating with the school. And so that's going to talk to them about what the goals are, what the deficits that your child has are, and what needs they're going to have moving forward. You want to have a very tight kind of connection with that, because you don't want to end up getting home, setting all that up, and then trying to get to school and having the school have no idea what's going on, potentially being behind, or them trying to give your child all the schoolwork to make up. It should be kind of the appropriate amount just to make sure they're on level and keeping where you are. So it's a lot of conversation. And then rehab psych, usually psychologists within the program, is helpful for everybody. The child, you know, has a big deficit now, but the families are having struggles here, right? You just lost a lot of expectations, a lot of thoughts of what you were going to do with your child down the road, and you don't know kind of what's going to happen moving forward. And so making sure that you're meeting somebody and chatting, and kind of running through those things is really important. All right, so once you get home, you know, there's another whole slew of things that you can do. So it kind of gets broken up by age, I think, and it's a good way to think about it. So we have a few kids that are younger, so there's early intervention here. It goes by different names elsewhere, but I looked up most of the places everybody was, and it's Sooner Steps in Oklahoma. So that was clever. Early Steps maybe in Florida. I think France has early childhood education and care or something. But everybody seemed to have at least some government program that provided therapies to the young kids. So this is important. I think if you're going home from the hospital and you're worried if they have some of that white matter disease, those small strokes, and you're worried about development, you can call them to come out and do an evaluation. Kids with strokes really should be followed, even if it's on consultation. If they don't have any obvious deficits, probably should be followed on consultation at least monthly, just to have another set of eyes helping you decide whether they're hitting the milestones appropriately. You know, there's a range for when we expect kids to walk, 9 months to 15 months or so. So are they on the early side or on the late side? Is this abnormal, or is this just within the normal range? And so kids with strokes, we kind of push to keep them involved. And that kind of goes as you're moving forward, because when you get to 3, there's a transition usually, at least here in different states, in different cities, or countries, it may be a little bit different, but I think it's generally the same. When you get to 3, it switches over to your district. So the school district kind of takes over that role of the in-school therapies, and being involved in early intervention makes that transition a little bit easier. So we've had some kids where the early intervention said, oh, they're doing great, they're 2.5, we're going to transition them out. Well, that is just the worst time, because now if something were to pop up during that three-year-old stage, it's a lot harder to get them involved in therapies there. So we do encourage you to kind of push to keep them involved in early intervention, at least through that school age time period. And then once they go to school, there's a lot of different ways to do it. So before they actually get in, you kind of have an early intervention program or early individualized educational program, or a 504. The big difference is kind of the goals, right? So a 504 program says that you have a medical diagnosis, you can take breaks because you get tired. There's no real necessarily goals moving forward. They may do stretching and that kind of stuff, or other PT, but it's not that they're setting out what we want to accomplish by the end of the year. Versus an IEP does have those kind of goals and a more integrated approach. The big difference, and this is something that I do have families kind of come to me and asking, is that the goals for school therapies are much different than the goals for medical-based therapies. Their goal is to make sure your child can access the curriculum. So their occupational therapists will work on handwriting, that kind of stuff. If they're able to get to school and participate in all of that, that's sort of what they're expected to do as a therapist within the school, which may be very different from our goals on the medical side. And that would be a reason to be doing outside therapy, a reason to have physical therapy, occupational therapy, some of the complementary therapies outside if you have other goals. And we've kind of switched from just doing therapies because it's draining. You get a ton of doctor's appointments. Going to therapy twice a week in addition to school and everything else can be exhausting. So I think one of the switches that we've seen in some of these chronic kids is that we're trying to focus as they get older on goal-based therapy. So during the summer, we really want to make a big push to see if we can get them ambulating better, more efficiently. We want to try to, work on their upper extremity, range of motion and function, that kind of stuff. And so we'll do a course of therapy to kind of get them through. Not to say that there's not some maintenance type therapies that happen, but that is one thing to just think about as you're moving forward. And then the early intervention up here, actually, and I trained down in Philadelphia, is very different from down there. Up here, they get kids involved in hypnotherapy, they have aquatic therapy, and that's all part of it, early intervention. That did not happen in inner city Philadelphia. So I'm not sure about how it goes in different states and that sort, but it's something to kind of pursue. There's different roles for each type of therapy, and active two kids are a little bit different, and they can't take the heat and the cold and that sort. So you want to be cautious with it, but it's something to look into. And then finally, just to talk about some of the medical management. So as a physiatrist, we do kind of the inpatient rehab consults, but we also help manage a lot of these kids in terms of their function once they get home. The things that we really focus on are pain management, making sure that there's nothing limiting what they can do in terms of therapy, getting to school, doing the things that they want to do in terms of hanging out with their siblings and their friends and their family, and getting outside and doing stuff. Spasticity after stroke, there's kind of a curve that they follow. Often you get like a flaccid limb immediately after the stroke, and then you develop spasticity. There's things that we can do to manage this. Again, this has been, I think, one of the bigger topics in my mind as we've been going through with the smooth muscle and the blood pressure issues. So there's a range of how you can treat spasticity, from stretching and therapy, oral medications, focal tone management with like Botox or Dysport, so the botulinum toxins, to surgeries with baclofen pump injection or pumps and that sort into the spine, which I haven't seen any kids with this disease happening. But there are kids with spasticity. And so most of the oral medication, most of our first-line medications, baclofen, clonidine, tizanidine, all affect the blood pressure. And so I've been recommending kind of avoiding a lot of those medications, not off of anything that I've seen. I haven't seen any kids with any bad outcomes, but it has been something I've been trying to sort of veer elsewhere. So if we can focus on focal tone management, maybe do Botox injections or Dysport botulinum toxin injections to limit kind of the systemic effect of this. And there is one medication that affects the skeletal muscle peripherally as opposed to centrally acting, ganglion. I have made some recommendations there. Again, this is all sort of theoretical. I'm not 100% sure. It'd be interesting to see what other people thought, but that is just something to think about, because when you do go somewhere and they see spasticity, baclofen is going to be the first line, clonidine will probably be the second line. Valium is up there, and that still does have a smaller risk, but a risk of hypotension. And so just something to keep in mind if you're going through. And then finally, neuropsych testing, I think is really important as we go through transition. So as these kids go through school, before they start, first grade, you want to get a good sense of where they are, whether they've had any subtle cognitive deficits and what their learning styles are, because that can help inform your IEP and how you're getting through school. We also usually recommend it kind of third grade when they're starting to transition from learning to read to reading to learn, and then sometimes up around seventh grade when they're got a lot more going on in school and have to switch classrooms and do all, they're just expected to manage a lot more on a day-to-day basis. So I think that was everything I was going to talk about right now.
Thank you so much, both of you, Lisa, Brian, and Kate, Cassie, guys over there. We're gonna take, thank you.